Hello, everybody. It looks like everybody's here. We have 79 participants so far. And I want to, if you can advance to the next slide, please, Josh. I want to welcome everybody to the COVID-19 Beyond the Biology series. I'm Graciela Jaschek. I'm assistant professor in the Department of Epidemiology and Biostatistics. And today I'm honored to moderate a highly qualified panel of participants. The panel speakers are Dr. Terri Upman. She is Miriam Sturl Endowed Term Professor of Nutrition, Professor of Nursing of Children, and Assistant Dean for Community Engagement at the University of Pennsylvania School of Nursing. Dr. Patricia Bradley. She's Associate Professor at the Villanova University M. Louise Fitzpatrick College of Nursing. Ms. Danielle Parks, Population Health Specialist at Independent Blue Cross, and Ms. Veronica Hill-Melbourne, President and Chief Executive Officer, Spectrum Health Services, Inc., and Chairperson for the College of Public Health Board of Visitors since July 2018. Thank you very much for being here with us today. So before we start with the panelists, I want to let you know we are going to be addressing how racial and ethnic health disparities are shaping the impact of COVID-19. Next slide, please. The panelists will explore a variety of topics that will shine a light on health disparities and their consequences. They are going to be discussing perceptions, stigma, and unconscious bias in higher risk populations, how COVID-19 is worsening disparities and the role of community health workers, testing and deficits in community education, telehealth, and how it can help mitigate some of the negative outcomes resulting from minority populations' medical distancing, COVID-19 health and access inequalities, the impact of social determinants, and then I'll ask panel members to discuss in a couple of sentences what we've learned and what we should do next. So I'll ask panelists to leave us with some thoughts. We will also have a few minutes at the end to answer questions from the audience. So please use the chat function to send your questions to the panel members as the panelists are discussing the topics. Okay, so as we speak, our country is being torn apart by demonstrations and violence that are the result of centuries of racial and ethnic inequality and oppression. Leaders, institutions, and community members are facing off over the policies and practices that undergird structural racism. As a community organizer of 25 years, I often witness the us versus them mentality, the indifference and the hate. I would always ask people at meetings, what makes you believe that they are different from you? It is our common human desire, theirs and ours, to do better for our children, to have a job, a home, to have dignity, and to be respected. This led to many difficult but fruitful discussions, or sometimes I would say shouting matches. But dialogue and empathy go a long way. But the us versus them mentality, the indifference and hate have been long institutionalized. And the sad reality is that there are stark social differences causing health disparities that cripple Black and Brown communities. Our panel discussion will focus on the health disparities that are being highlighted during the current pandemic. The coronavirus is transmitted very efficiently, and we are all susceptible to infection, all of us. So you may say that anybody, regardless of their age, race, ethnicity, or economic status, are equally at risk for being infected and developing serious disease or dying. But that is not what we are seeing. What we are seeing are stark disparities. Some say that people are getting infected or dying at higher rates because of pre-existing conditions such as diabetes, hypertension, or obesity. But as we dig deeper, we see there are social conditions that contribute to pre-existing conditions and lead to serious health disparities. Americans, African Americans, Latinos, Native Americans, and the poor often experience social conditions that carry risks for them. And these conditions are not of their own choice. Discrimination, stigma, bias, and language barriers can isolate entire communities from testing, healthcare, and information about COVID-19. Black and Brown community members often are less wealthy. For example, the net worth among whites is $171,000 compared to $18,000 for Blacks and $12,000 for Hispanics. They have lower incomes, $71,000 for whites versus $41,000 for blacks and $30,000 for Hispanics. These communities have higher levels of poverty, 8% for whites compared to 21% for blacks and 18% for Hispanics. They experience higher risk with jobs in the essential workforce and the use of public transportation to commute. Many also live in crowded housing, have less access to technology or information from the internet and social media, and have less access to equitable healthcare. So now that I have introduced the subject, let's hear from our panelists. Dr. Bradley, much of your work focuses on psychiatric, mental health, nursing, and cultural competence in health. Can you please begin by introducing us to some of the perceptions, stigma, and unconscious bias in higher risk populations, and what role does structural racism play?
Thank you, Graciela. I thank everyone for the opportunity to be here today and to participate in this discussion. I come to you, as Graciela says, as an associate professor at Villanova University at the College of Nursing. And my teaching responsibilities are in the psych mental health nursing course, as well as health promotion and cross-cultural communication. So I would say to you that my work during the day has a lot to do with communication and understanding about vulnerable populations. And then my work in the community as a researcher and a community advocate is to work with people in terms of giving a voice to the voiceless. So the first question, I would have to say that I had more questions than answers when I was first asked to be on this panel. And my first question was, who am I? Who am I to talk about this issue? And I also wanted to know, how could we talk about this issue without talking about racism? So I thank you for the question. We've heard a lot about what's happening today. That was my second thought. How can I speak and speak in a coherent way when I'm filled with so much emotion about what's going on today in our world? So yesterday, I was fortunate enough to be involved in a group at Villanova, our intergroup relations, and we had a space to talk. And in that space to talk, we had a space to share our emotions, to share our thoughts, and to share our feelings, and to share them with our allies and people who really have a thirst, wanting to understand how they can participate and how they can be a part of it. And so I think about that with our work with the community. And I want to shout out to all the students who are on this call. You are our future. You are the ones who are going to be engaging with the community and engaging with an understanding of all the things that are going on right now. So I want to say that we hear about racism. Most of us on this panel have felt racism. We live it every day. And we look at the individual racism, the phone calls that go to the police that say somebody's in a place they don't belong, when in fact they're just watching birds in Central Park. Sleeping on a couch in a dormitory. So those are the kinds of things that are affected individually, and then institutionally, our criminal justice system and our laws and our rules say that that person can be arrested, not the person who called and made a false accusation, but the person who is just being in the world. And then we look at how our policies are set up in terms of systemic racism, and they are considered many times to be race neutral, but then they get interpreted and implemented in such a way that it's the people of color are the ones who get the implementation. Moving that along to structural racism, where we're really looking at, Tricia Rose talks about structural racism as being normalization and legitimization of those policies that discriminate against people of color and actually benefit white people. And she talks about how that impact creates a system where you have, excuse me, I'm pretty emotional right now. Yeah. But it's a system where what you end up seeing is the chronic pervasiveness of these rules and regulations against people of color. So when we're talking about COVID right now, and we're talking about what people learn as they're growing up about people of other races, and then apply them in a systematic way to create not only the disparities, but the inequities. And I would say that there are some people who really don't know that they don't know. And so, and many times what we're left with is teaching them what they don't know. Yesterday in our class on cross-cultural communication, we had an exercise where the students were looking at this image of perception. And for those of you who have been in school and been in psychology class, you've probably seen this older woman and this younger woman image, and you have to figure out which one you're seeing. And basically the students had to diagnose this patient just by looking at her. And the interesting things that came up in terms of this woman appeared to have a fur, she appeared to be younger, and so she got categorized in upper middle class or upper class. The older image also has a fur on, but for some reason she looks elderly and haggard and poor. And so she got put into the category of poor. Now, this was an exercise that was fun, but it also was an exercise to say, what were your assumptions that gave this person the name you gave them, the ethnicity that you gave them, where they came from? And this happens every day in our healthcare system. Patients come into our institutions and they get looked at, and their appearance will then dictate what kind of treatment that they get. Do they have insurance? So that was a question that I asked about this woman. Does she have insurance? Well, if she was upper middle class, yes, she did. And the decision, did she have Medicaid versus Medicare when she's an older woman? And what happens when you say what kind of insurance you have in terms of who you get referred to and what kind of treatment you get? And I know that our other panelists are going to be talking a little bit about that in terms of their systems and how things are working. But I just want people to really think about the fact that in our country, we have been set up for the longest time to look at people of different colors in a less than way. And when we're asked about what are the solutions, what gets pointed to more than anything is changing those people, you hear the pronoun, those people's behaviors. So it all goes down to behaviors and interventions that are supposed to change the patient when in fact the system is set up against them already. So I just want people to think about another concept that I'd like people to really think about is when we talk about social distancing is a privilege. It's a privilege to stay home or to work from home. It is a privilege to have space to be in different rooms in your house. It is a privilege to be able to go to school online, to have the internet, to have the laptops, to have the computers. So we know that structural racism affects us in our housing, in our employment, in our education, and as well as in the criminal justice system. So let's look at, you know, my grandsons who I call my daughter and say, they're in the house, right? Because I'm worried about if they're out in the street and they get picked up because they're walking down the street. I'm going to stop talking right now because I definitely could go on, and I don't want it to seem that it's about me. Thank you, Graciela. You're on mute.
There we go. Thank you very much, Dr. Bradley. It was very, very interesting what you introduced. And I think that it brings it to the fore. Your emotions make it so much more real for everybody. Now I want to turn on to Dr. Upman. And Dr. Upman, how is COVID-19 worsening disparities in populations that suffer with chronic health conditions like pediatric type 1 diabetes, for instance?
Well, Graciela, thank you so much, Temple University, my alma mater, for inviting me. And I'm happy and sad to be here today. I'm happy to be here with my colleagues, Dr. Bradley, who I've known for many years. It's so good to see her. And I'm sad because of the situation that brings us here. So when we talk about disparities in diabetes, I think it's really important to recognize that there are things that have come to light because of COVID-19, but disparities in diabetes have been going on since the time of diabetes. And when we look at children with diabetes, we know that children with diabetes have poorer diabetes control and have higher rates of complications and higher rates of mortality than children compared to non-Hispanic white children. And I also want to give a quote, and Dr. Martin Luther King said that of all the forms of inequality, inequities in healthcare, injustice in healthcare is the most inhumane. Mm-hmm. And it will be, I'm sure that there will be threads that go throughout this entire session. And in terms of what Dr. Bradley said about why are these inequities, my research at the University of Pennsylvania, I'm also a practitioner in the Division of Endocrinology at Children's Hospital of Philadelphia, has focused on disparities, specifically racial disparities. And often the interventions have focused on changing behavior. And we have been completely unsuccessful in moving the needle regarding diabetes disparities in children by focusing on changing behavior because we have missed the boat in terms of structural inequality and racism. So prior to COVID-19, we have undertaken a program to integrate community health workers into our team because the professional team has been unsuccessful. And the community health workers working with children and families with diabetes have focused on social determinants of health, have focused on those factors that really preclude a family from being able to adequately care for a complex disorder. So now in terms of your question, what's happened during COVID-19 and all of those issues that have already been brought up, not just the privilege, but the luxury of being able to work at home. So we have families who are working and children who are home because there isn't school. And without school, there isn't the oversight of school nurses. So children are home managing complex disorders without an adult. We have families who usually the grandparent would come into the home. However, I know of families who don't want a grandparent in the home because they're afraid that the grandparent will be at risk for contacting COVID-19. So we have families who are food insecure. When we have looked at our data, we identified that 25% of our marginalized families are food insecure, but interestingly, when that question was posed by community health workers, it's 47%. There's shame and embarrassment associated with being food insecure, but that lived experience shared by community health workers has really been able to obtain data that we haven't before. So children are home with diabetes, they're home without adequate oversight, they're home without insufficient food, and we are connecting via telehealth, or we're trying to. But many of our marginalized families are not able to connect via telehealth, and it takes a lot of support and also the technology that's needed to adequately connect via telehealth. So those are just a few areas where children with diabetes are faced with injustice and inequity beyond what other families are faced when the children are from marginalized populations.
So you recently co-wrote a terrific op-ed for the Inquirer, which talked about the role of community health workers. Can you talk a little bit more about the role of community health workers in helping mitigate those disparities?
Yeah, so I also want to say that I'm the Assistant Dean for Community Engagement at the University of Pennsylvania School of Nursing, and I oversee the strategic vision on engaging with communities. So my research has been largely focused on community engagement, upstream interventions for addressing social determinants of health. And for those students who are listening, I strongly believe that community engagement and addressing social determinants of health is fundamental regardless of where you practice. So often we think about community engagement for those nurses who are going to practice in communities, practice in schools, practice in public health, but it is even more crucial for nurses who are in inpatient settings where those issues are often not addressed. So the community health workers, again, share a lived environment. They are non-professionals who have been making home visits, another issue with COVID-19, but prior to COVID-19 had been making home visits and again, addressing social determinants of health. And our early data show that although the community health workers are addressing social determinants of health with children and families with diabetes and not addressing diabetes management, which is how professionals generally focus on trying to improve diabetes care, diabetes outcomes have been improved. Our preliminary data show that diabetes outcomes are improved by a community health worker addressing social determinants of health. And I'll give you an example. So a community health worker had one visit in a home, and the patient responded, "This was the best thing the Diabetes Center has done for my child in 10 years. I am that patient's diabetes nurse practitioner." It's very humbling. I've seen that child and family every 3 months for 10 years. So I was very interested in what happened in that visit. And the community health worker walked into the home and saw that the roof was leaking. If any of you have ever had a leaky roof, and I have, it's impossible to think about anything else but that leaky roof. When she saw the leaky roof, she arranged to have the roof repaired. I saw that family 2 weeks prior. I never asked about the roof. I focused on blood sugar management. I focused on insulin. But again, not asking about, not knowing that there were issues in the home, that there were structural issues in the home, my focus was completely in the wrong direction. And the community health workers also work with the providers to better understand our relationships with families and actually sit in with visits that we have with families to help us better understand how we communicate, how we miscommunicate, how some of the instructions we give can be offensive. So the addition and the integration of community health workers has really helped us look at societal racism, societal barriers, structural racism in a way that we have not been able to do before.
Thank you so much for your answer. That is very interesting. I want to turn now to Ms. Hill-Melbourne. So I understand that your organization recently opened a large testing site in West Philadelphia. Are people in the community taking advantage of the testing made that available? Or can you share some of the successes and challenges?
Sure. Thank you so much. I feel very, very blessed to be able to speak with you this afternoon. So Spectrum is a federally qualified health center. We've been serving at-risk populations in Philadelphia for over 55 years. We offer a variety of services: adult and pediatric medicine, dentistry, podiatry, OBGYN, behavioral health, nutrition support services, and we offer an integrated model. To Dr. Lippman's point, our professional team does also include community health workers, and I believe that we do an exceptional job at addressing some of the health disparities for those populations that struggle with multiple chronic conditions like hypertension and diabetes. And when COVID hit back in early March, and when it was at its peak, many federally qualified health centers were struggling and scrambling to figure out how to develop a response. And many of us struggled to retain available staffing resources for a variety of reasons. Many of us saw our visits decline substantially, where people were afraid to come out and see their provider. We also had families that, were now forced to stay home and care for their children because the school systems were closed. Transportation was a barrier. Also, another struggle for us as a healthcare provider was securing the appropriate personal protective equipment. And so, although we desired to provide testing early on, we were unable to do so. And we found patients coming to our center afraid, sick, wanting testing, and we were not able to provide it. However, as soon as we were able to secure the appropriate PPE, i.e. The N95 mask and the testing kits, we began testing. We opened our center outside of our West Philadelphia location in April. We have 3 centers currently, one in West Philadelphia, 52nd and Haverford, another in North Philadelphia, right down the street from Temple University, 1415 North Broad, and 1325 South 33rd Street. And we had to close 2 of our centers and suspend services temporarily because of lack of PPE, available resources. And so we've consolidated everything to our West Philadelphia location. So with regard to testing, we are testing 3 days a week. We have tents outside of our West Philadelphia location. Patients are responding very favorably. It is certainly a need in the community. I think that the model that we're leveraging is very effective in that it's not a one-time test. Our goal is to link patients at risk with a healthcare provider that is there for them during the course of anything that could happen. We want to make sure that they are receiving the education that they need. We have an in-house pharmacy, a 340B discount pharmacy program, so patients can get the medications at a fraction of the cost that they might experience on the commercial market, such that they can have effective treatment for their chronic conditions. So patients are responding very well. Our schedules are full every day that we are testing. I think another unique feature of our testing site is that it offers walk-up. Many of the testing sites throughout the city of Philadelphia were drive-up. Well, many of the patients that we serve don't have a vehicle. So they rely on public transportation, or they're coming from local neighborhoods. So this is a well-received solution for those patients. Very, very effective. Patients can simply call to schedule an appointment at our main number of 215-471-2761. It's working.
Thank you. I understand that your organization was able to pivot quickly to telehealth to ensure continuity of care. Are minorities using those services, and has this been successful? Or, have you experienced any challenges with telehealth?
Well, there were several challenges. I remember back in early March, I was on a call with a number of CEOs of other federally qualified health centers across the city. And we were all sharing our survival tactics of how we were going to make it through COVID. And I organized a call with our two largest managed care carriers in the city. And we had a call with those carriers to plead for approval to provide telehealth and to allow us to use this as an alternative model to care. And I have to say that the insurers responded very favorably. And in fact, many of the carriers removed the copay requirement, which is another barrier to care. Patients don't have that copay. And so when they're looking at limited dollars, trying to determine, do I put food on the table for my 3 children, or do I go to the doctor to see about my diabetes? Often they choose not to come to the provider. So when we received permission or approval to provide telehealth, many of our federally qualified health centers, including Spectrum, were scrambling. We served 14,000 patients last year. How do we reach those patients to let them know that telehealth exists as an alternative to care? And what is telehealth? So, and many of us did not have the technology, sophisticated, platforms to do telehealth. And our payers were gracious in that they didn't require a sophisticated platform. We used whatever resources we could get to reach our patients. Cell phone, landline, 2 cans in a string. I used every available resource, medical assistants, community health workers, social workers. We were all on the phone calling all 14,000 patients to explain to them how this works. And people were initially reluctant, didn't understand, thought that the only way to engage with their provider, doctor, nurse practitioner, behavioral health consultant, was to come into the center. And we still offer that. However, telehealth offered a great alternative. People did not have to fear to come in contact with COVID carrying patients. They could receive care in the comfort of their own home. And it was well received. I would say 95% of what we're doing right now is providing care through telehealth. Highly effective model. People are receiving care that they have gone without for many, many years. Now they're engaged with a provider. They're having their chronic conditions managed effectively. It is a win for us all.
That is so cool, so interesting.
Yes.
So now I want to go to Ms. Parks. In your role at IBC, what are some of the COVID-19 health and access inequalities that you are seeing right now?
I think initially, the first inequality was testing. I think it was a struggle for some people to actually get tested. There was a lot of misconceptions in terms of who should be tested. Even with, some of the sites that started, they were drive-up sites, and so that provides a barrier as well. And so the Black Doctors Consortium, which is a great project, went to local neighborhood, partnered with churches, and really provided testing in the communities. And so I think that was the biggest barrier. I think some of the other issues was a lot of the information that we got about COVID-19 in the beginning, when they were talking about the populations that were at risk, and that, these are older populations and people with underlying issues. And when we talk about Black and Brown people, our life expectancy is a lot lower. And so we're not talking about people that are at risk that are in their 60s and 70s. We were seeing more people's in their 40s and 50s that were being, really hit hard by COVID-19 and actually dying. And so those were the biggest things that I saw in the beginning.
Interesting. So what are some of the ways IBC is addressing this issue?
And so the first thing was just making sure that the patients, our members, had access. And so I was proud to be a part of IBC when they hit the ground running initially with telehealth. They were one of the first providers to really send information out to make sure providers knew that it was available. As Veronica said, in terms of waiving the copays and making sure that testing accessibility was going to be key. Because we know that in terms of, these disproportionate numbers in terms of those that are impacted by COVID-19 was going to travel along the same lines as a lot of the other chronic illnesses that we look at. And so we knew right away that people of color were going to be disproportionately impacted by this, and we wanted to make sure that the resources were available.
That's so wonderful. What role do health corporate and government leaders play in addressing this issue, do you think?
I think the biggest thing, as Dr. Lippman said, is we have to stop addressing this from an individual level. I think for eons, as far back as I have been in public health, and I won't say as long as that's been because I'll age myself, but as long as I have been involved in public health, we have done individual interventions to get people to deal with these issues. So if you're diabetic, we want you to eat better. We want you to exercise. And so that's really the low-hanging fruit. I think as people that are in the front line that are addressing this, it's really easy for us to tell members, you can be better if you do these things. But there is a lot of macro issues that we need to deal with in Black and Brown communities. Just since this has kind of happened, we've all heard a lot of the stories where people have went into hospitals, have been diagnosed with COVID-19, really not doing well, sent home, went back to the hospital, sent home again, and have actually died. And so that access to quality healthcare is something that we have to address. We have to address the social injustice and the racial disparities, not at the individual level, but really talk about poverty, about education, about food deserts, about access to quality care, about unconscious bias, because all these things are going to impact how people respond and how people deal within a pandemic. We've seen it with HIV, we see it with breast cancer, and so COVID-19 is different.
Interesting. So you have been mentioning many social determinants of health. Can you name a few and explain why they are important for health leaders to pay attention to?
I think we have to deal with poverty. We have to deal with education. I was so happy to hear the story that Dr. Lippman said. I used to be a community health worker eons ago, and we do pick up things that sometimes practitioners and providers don't see. So it's no way for us to deal with a pandemic without dealing with those larger issues. As Patricia said, social distancing is a privilege. Everybody does not have access to that. We have to, as larger organizations, discuss essential workers, and not the nurses and doctors, but those essential workers that are essential, but those that are expendable. We do have some essential workers that are living below the poverty level, that because of the work that they do, we get the things that we have. And so those people that are working as home health aides, those CNAs, people working in supermarkets. And so we have to address those issues as well. I had a conversation with someone last week, and they were talking about environmental racism. And, I had to say, people don't move into environments where racism exists. Racism exists in those environments because we're there. And so we have to be able to address these macro issues. And it's a lot. It's a huge task for us as public health practitioners to deal with, but they are real. There was a story out in Chicago where there was 50 polling places that were moved to senior centers that were ran by public housing because some affluent areas refused to have polling places open during this pandemic in their communities. And so we send people to the most at-risk population that there is. And so this just really continues to manifest how Black and brown people have been looked at as disposable.
Thank you so much. As you are all talking, I'm realizing you are my future students. The students I'm teaching, they are you. And I always tell them, you know, you are the solution. You go out there and then do everything that you can. You are the solution. And I really feel so honored and happy to participate, because it gives me a vision of what the future for my students are. And sometimes you have students and you forget that who are they and who are they going to become. So this is wonderful. So I have one last question for each of you. If you can tell me in one paragraph, what have we learned and what should we do next? So let's start with the last one. So since you've been talking, Ms. Parks.
And so I hope that we have learned that focusing our funding and resources in individual level interventions does not necessarily work. We can no longer ask that communities that are marginalized kind of pull themselves up by their bootstraps and make things better. We have to deal with it from a macro level. We have to start dealing with the social determinants of health. I was at a church right before COVID-19 hit, and I do a lot of diabetes education. So Dr. Lippman, I will be emailing you. And I had one of the participants come up to me after the workshop, and he talked about the fact that his hemoglobin A1C, he hadn't had one taken, but his blood sugar levels had been really, really high. And we talked about medication adherence. He said, well, I haven't been taking my insulin because my electricity was cut off a month ago. And so he didn't have a way to refrigerate it. And so these are the type of things that as a healthcare system, we have to try to address in order to impact change.
Great, thank you. What about you, Ms. Hill-Melbourne?
So what I've learned, and I hope our managed care carriers have learned this as well, is that telehealth is a viable solution. Prior to COVID, it was not something that was an approved methodology for care. I think we've proven that it is an appropriate model. And I think one of the things that we need to focus on is our continued efforts to explore innovation that allows us to address the social determinants of health, leveraging more sophisticated technology resources. Also, I think we need to continue to explore how to provide healthy food options, how to provide for reliable transportation, to leverage the expertise of more paraprofessionals like community health workers. We have to explore affordable housing. All of these things will help to equalize the disparity amongst Black and brown people and improve access to care and services.
Great, thank you. Dr. Bradley. You are muted. There we go.
Yeah, I think I am muted, period. Right now, throughout this, I would say that it's not so much as what I've learned, but what we have seen, and COVID has shown a spotlight, a really glaring spotlight on the fact that this is our history and it's continuing, that it's cumulative, that it's chronic, and that the only way to change it is to change the system. And so we have to have more than our individual workers out there trying to help individuals if we really want to make things different. What I do know is we have a legacy of surviving. We have a legacy of resilience. We have a legacy of putting faith over fear. And I think that that is continuing as we look at what's going on today.
Thank you. Dr. Lipman.
So I think, again, I want to think more broadly about the situation and the issues that we're facing today in terms of the pandemic, and also the tremendous turmoil that we're in that's just a reflection of centuries of racism. I hear a lot, we're all in this together, but we're also in this differently. So we're together, and I acknowledge that my experience as a white woman is very different. But when we say that we're in this together, what does that really mean? And I'm going to read a quote that says it much better than I can. This was actually Dr. Joaquin Prince gave the speech immediately prior to Dr. Martin Luther King's I Have a Dream speech. And he spoke about what it means to be a neighbor, and we're all neighbors. And he said, neighbor is not a geographic term. It is a moral concept. It means our collective responsibility for the preservation of man's dignity and integrity. And I think that if we keep that in mind, although we are in this differently, that our neighbor is our collective responsibility, we can come together and hope that the future will be brighter. And it's been an honor to be with all of you. And I hope we move forward together, differently, but together.
Thank you so much. Those were very touching words. You all brought such important things. These are, as you say, the turmoil, these, traumatic, dramatic moments. I see them also as a moment for us to think about the future, to rethink our policies, to rethink our world. And let's hope that that's going to happen. I believe this is something I tell my students all the time. Think about the solutions. Don't point fingers, don't whine, don't fault others. Just take it on and find a solution. It's your job, it's your role. This is what makes you feel alive. This is what's exciting about education and knowing. Once you know about these issues, you cannot just leave them behind. You have to find the solution. So having said that, I have not seen any questions asked in chat. So there is one in the Q&A. So let me see. So Saluna Baju says, I would like to apologize first for straying off topic, but when I think about racial disparities in healthcare, I can stop myself from thinking about universal healthcare. We keep coming up with interventions to help the minority communities, but I wonder if making healthcare free for all would provide the best opportunity for these communities during COVID-19 and beyond. There is so much resistance to it politically and otherwise, which I understand, but I believe healthcare is a human right. What are your thoughts about this? Will we ever get there? What are some ways we can push for that? Or is there a better solution? Very nice question.
Very nice. I'll touch on this a little bit. I truly believe that universal healthcare is a start, but we really need to start in our medical schools. We need to start with how we train our medical providers, because we've seen this in brand new schools that have been built in the city. They build a brand new school, they put brand new books in it, all the great technology, and they provide it to all the access to the students that need it within their community, but they still see poor education outcomes. It's bigger than just that. And so we can have universal health care. And so therefore, that does address one issue. People have access, but how are they treated when they get there? Are we still dealing with the unconscious bias? Is our, the way that we are viewed and the way our pain is managed, being looked at differently because of the color of our skin? And so, again, that is a great way to deal with access, but it's not necessarily dealing with quality.
So I'd like to speak to that too in terms of universal. I think it certainly times like this beg the conversation to continue. Leading a federally qualified health center is in essence universal health care for all, because we don't turn anyone away. All patients are able to receive the same quality of care as someone that has insurance. Our providers come from some of the finest institutions across the country. All patients are treated with the same level of dignity and respect, and receive an array of services, regardless, again, of their color, sex, religion, sexual preference. And so that's something we take great pride in offering. And I think it is, it's a right that every individual should have access to quality health care.
And I think as you're talking, that one of the things that we always have to remember, that in our communities, when we talk about access, we always have to add the word quality care, not just access to care. And we have to make that an issue, because it's not happening. And so, Danielle and Veronica and Terri, I'm just saying, I know we're doing the work, and Graciela, I'm glad you say to your students, don't whine, just do it. That action speaks louder than words. And that's what we're hoping for.
I want to say something else about the students, if I might. So when someone makes a decision to enter into the field of public health, it is not something for the weak and frail. And as healthcare, public health community providers, we don't run from the fire, we run to the fire. And I think that's something that we need to instill in our students who are in programs about to graduate, that the time for their passion is now.
Dr. Lippman?
No, it's hard for me to add anything to what's been said in terms of we want healthcare for all, we want quality healthcare for all, and we want to make sure that we train and educate healthcare professionals with a commitment to social justice and an acknowledgement of structural racism that needs to be addressed by all of us. And also, I can't leave this call without making a plea to everyone who feels powerless right now. Everyone has power. Vote. It's really important to vote, and it's really important to make sure that those for whom you vote are held accountable to what is needed in the community and in the country. So this is a time in the country where we really do have that power. And in the last election, many stayed home and did not vote. By voting, we can change the course of history. So I'm going to end on that note, which may seem tangential, but really is very central.
How true what you are saying. Okay, I'm not going to get political, sorry. But that's very true, vote. And that's very important. Make your vote count. The popular vote is very different from the final vote, and we need to be counted. You do have a voice, so that's very important. So I don't see any more questions, and yes, go ahead.
I was just wondering if I could add just for a moment. I chose my background today as something that was going to help and remind me of how to be calm, serene, and gentle as my sisters and brothers of Chi Eta Phi nursing sorority teach me to be. The other thing that before we go, if we could say happy birthday to Danielle.
Yes, happy birthday.
Took her birthday
Hey.
to be with us today and share
Yes.
that
Wouldn't
wisdom.
love to spend my birthday talking about this. This is one of my passions. I'm also a professor at LaSalle. I teach in the School of Health, Public Health and Nursing. And, you know, in developing and growing the next public health leadership, we talk about this quite often because I want to make sure that my students are prepared to be able to continue the work that we are all doing because we're getting a little more seasoned.
Well, thank you very much. Please join us next week on Wednesday, June 10th at 1 p.m. for a conversation with regional healthcare leaders. The title of that COVID-19 Beyond the Biology series is How the COVID-19 Pandemic Has Changed Healthcare Delivery and the Patient Experience. To learn more, visit cph.temple.edu/COVID-beyond. And to support the College of Public Health, our students, faculty, or research, please visit our secure giving page at cph.temple.edu/giving, or contact Natasha De Luna, Chief Development Officer at the College of Public Health. So stay up to date on the pandemics through the college's coronavirus resource page, which includes faculty expertise about preventive measures, disease transmission, and status of the outbreak from a public health perspective at cph.temple.edu/coronavirus. And the last, I want to let you know, this session is being recorded and you will be able to access it. Thank you all so much. This was really very interesting and a very important and timely conversation. Thank you very much and see you next week.